with you virtually at least. Sorry, I can't be there in person. And I trust you've had a great day. My day is just starting. And yeah, I'll be talking to you a bit about global health workforce perspectives on recruitment and retention. But before I get into that, just let me cite myself so that you know where I am talking from. So I'm based in Cape Town, which is, of course, the most beautiful city in the world. And if you didn't know that, you better come and visit soon. Although I work for Stellenbosch University, and the town of Stellenbosch is a little bit inland. It's a small, very historical town, maybe university town. There's no large hospital there. So in fact, the medical school of the university is in Cape Town. And then so I have an office there, and I also have an office in the town of Worcester that you'll see further inland, which is where our rural clinical school is based. So I probably don't need to tell any of you why we need to talk about rural health workforce, but I want to just give you some understanding in terms of poverty and rural health. That rural is much more prominent, and it might be big in Australia, but if you look at lower income countries, it is much more prominent. About 67% of populations in lower income countries are rural, and extreme disproportion of people who live in extreme poverty or multidimensional poverty live in rural areas. And the resulting health equities are things you are probably familiar with, but again, in lower income countries, it is even more so in terms of things like stunting, under 5 mortality, access to care for people with non-communicable diseases, and other social determinants like things like access to water and sanitation. It is much more of a problem in rural communities. And the note there is that all of these things are things that can be remediated with sufficient resources. So if we talk about rural health workforce, we have to talk about it within the context of a broader perspective. So there's addressing the social determinants of health as things that cause the rural health equities from at a causative level, as well as addressing it in terms of responding to that, strengthening rural health systems, and a particular component of that is the human resources component. That's shown a little bit differently in this slide, which is looking on the one hand, the socioeconomic disadvantages, on the other hand, the low workforce densities, which both impact on health systems outcomes. And an important element of sustainable, yes.
It's just one minute. Are you showing slides?
I am sorry. That's thanks for.
Right? No, because we can't see them.
Yeah, I'm glad you stopped me. Otherwise, you don't know what I'm talking about at all. Sorry about that. Now you can see them, can you? Yeah.
Yes.
Yeah. Sorry, I can't see you when I'm presenting. So yeah, it's not. I'm not going to go back through those. Hopefully, but go back through all of them. But I was talking about the two-tiered response in terms of determinants and health systems, and that really the focus on rural health and health workforce is balanced with the issue of addressing social determinants of health and in the context of sustainable development goals. So there's been a number of documents, commitments, etc. You probably all know about the Sustainable Development Goals. There was a global strategy by WHO in 2016 around global for human resources for health, the Astana Declaration on primary health care, and there was a high-level meeting on universal health coverage, which is a critical part with the political declaration of that, which included health workers. But this work driven by WHO has actually gone back much further than that. And I was involved with the first set of recommendations in developing access to increasing access to health workers in remote and rural areas, which was in fact launched in South Africa when I was still at Wits University, which Paul referred to. And why this document is significant, it was the very first time that WHO recognized rural as a specific issue that needed specific attention. And so that was an important document. We did some preparatory work for developing that document in Journal Rural and Remote Health, of which Paul, you probably know, is editor-in-chief. That remains still the highest cited article in Rural and Remote Health, looking at interventions to address this problem. So as WHO was planning towards the Year of Health and Healthcare Workers in 2021, the decision was made that those guidelines, those recommendations needed to be revised. And that led to the development of the new updated guidelines in 2021 on health workforce development, attraction, recruitment, and retention, of which Paul and I were both part of the guideline development group. What has happened that's just started when we did the 2010 ones, but now has really become quite strong, is that any guidelines in WHO have to have evidence behind them. And part of the reason for the revision was the fact that evidence continues to build up. And I'll show you that in a moment. So the recommendations fall into 4 groups that you can see there. 5 recommendations on education, 4 on regulation, 1 on incentives, and 7 on personal and professional support. But in WHO guidelines speak, there are good practice statements as well, which are things that are so obvious and so evident that one doesn't need to kind of provide all the specific references. And that good practice statement was any intervention should be internet connected, bundled, and tailored to the local context. In other words, you can't just choose one intervention and think it's going to make a difference. You've got to look at the whole perspective, the local context, and say, what do we need to put together? There's a whole set of things that need to be applied. Just doing one thing is going to make very little difference. I'm going to briefly mention these or go through the specific ones. I'm not going to read each one, but to give you a feel, and you can see for each of them the strength of the recommendation. In other words, what the guideline development group decided, how strong they felt that recommendation should be, and based on evidence and other factors. And then you can see from the certainty of the evidence, which shows there's still work to be done in terms of building up more evidence around these issues. The strongest one there you can see is enrolling students with rural background. We have the most evidence for that in terms of impacting on education, but we have all the others. And this leads to a rural pathway. And to step aside from the recommendations for a moment, I used to repeatedly use this slide of the pipeline. We always used to talk about rural pipelines, and it's choosing the right people, that recommendation I just talked about, training them in the right place, providing postgraduate opportunities, and supporting rural healthcare workers, which I think applies. But we're talking much more now about pathways, and that concept of the image of multiple paths that crisscross and come together and go apart. If you walk in a rural area, those kind of pathways that merge and separate and come together again. And we were involved in the WHO process as well to look at what we need to be doing to implement pathways, and developed a checklist for implementing rural pathways to train and support health workers. From looking at community needs to the existing workers and their scope, to the selection of health workers, education and training, the working conditions, accreditation, professional support, and then ongoing monitoring and evaluation. And that's available online, and there's a summary article that we were involved in writing as well. Now my slides have just stuck. There we go. So So the next set of recommendations were around regulation, that we need regulation in terms of things like scope of practice, the range of occupations needed. In South Africa, we have compulsory community service, it's called, that all health professionals have to do a year of public service after completing. In the case of doctors, after internship. Other health professionals, it's directly after completing, and that's quite common around the world. Surprisingly, only one set of financial recommendations around incentives, and that's because it's very difficult to calculate what makes a difference and how much you have to offer or what you have to offer in terms of incentives. I mean, the examples of fantastic incentives. One in a neighboring country in Africa, Zambia, gave each doctor would go to rural area a car. It had a wonderful effect, but unfortunately, doctors only stayed 6 months. There was nothing keeping them. They grabbed their car, worked there for 6 months, and went back to the city. So, you know, one has to think these things through quite carefully. And then a whole lot of personal and professional recommendations, which is about living conditions, about the workplace, the whole concept of decent work, and career pathways, which are all important. Coming back to what I said at the beginning is that in terms of putting these together, one has to select a bundle of strategies for the context relating to the relevance, feasibility, affordability, etc., to ensure that there's both investment to develop the rural health workforce, but also protection of rural health workers and the rural health workforce on an ongoing basis. And that requires multi-sectoral activity and action. Another perspective that says pretty much the same thing is work that's been done recently with a funded program called Recruit and Retain, which was northern countries, Canada, Norway, Scotland, Iceland, a number of others that got together to do this, and really putting together a practical way of looking at how one recruits and retains health professionals. And they have at the center put 5 conditions that they see as important for success, which build on some of the things I've mentioned before. Recognizing the issues, in other words, understanding the need. That's a starting point. Often that need is not recognized in different countries as being something that needs to be addressed specifically. Often there's the idea that, well, you know, if we just deal with health workforce across the country, rural is going to get sorted out, the trickle-down effect, rather than realizing that there needs to be specific attention and focus on that. Engaging residents, as we've said, that the consumers, the patients, communities need to be involved. Sufficient investment is critical. An annual cycle of activities really brings home the fact that we can't just do one intervention once and hope things are going to change. It's an ongoing process, and part of that is also ongoing monitoring and evaluation. I'm going to change tack from there to a critical issue that relates to international health workforce and that we continue to struggle with. And that is the issue of the migration of healthcare professionals, which has a significant impact on this. It's a complex issue and an ethical dilemma. Paul and I wrote an article back in 2002 around this, and it continues to be a significant issue. I mean, there was a paper published earlier this year with the exact title of this, and it still continues to be something that we haven't sorted out. So one paper that was recently published this year from Canada, which makes the note the fact that 29% of nursing and related occupations and 26% of physicians in Canada are internationally trained. But it also speaks to the fact that there's an ethical issue around any state's responsibility not to undermine another state's ability to provide healthcare services. Noting that there are multiple migration drivers, it's not a simple issue, and people don't just leave because they've been recruited. There are push factors and pull factors, etc. But ethical recruitment, they say, is possible, and that there are some examples of things that work, although they're actually quite rare in practice. And they refer to the WHO code, which I'll come back to, which has been agreed on internationally, adopted across the United Nations, but in fact, it's hardly worth the paper that it's written on, in terms of the extent to which it's been put into practice across the world. So people often say, oh, well, you recruit from a country, but often they survive on the income they get from that. And there are countries that aggressively market their doctors for export, as it were, and doctors and nurses, in fact. But yet, it's bigger than that. So there's an interesting article from this year from Zimbabwe, which shows some of the positive effect. They were looking at households in Zimbabwe, which has been really gone through hard economic times. And they find it clear that where there are people who have emigrated that are still connected to local families, it's beneficial. It cushions households from the ravages of poverty in terms of things like health seeking, income, education, number of meals. But note the point that immigration robs the nation of its professional, able-bodied people and has significant consequences for the rest of the community. So the families who don't have somebody sending the money, they suffer greater or more greatly because of that immigration of those few, which is an ongoing issue. So it is complex. In South Africa, some work done last year looking at migration of physicians showed that they found 11,000 registered South African physicians across OECD countries. There were 21,000 that found in data sets in those countries, but only half of them they could find were actually registered, and it's not quite clear. Some of them might have returned to South Africa, some of them might have retired, some of them might be doing other things, or maybe they're just not picked up in the registration systems. But that's a significant number of South African physicians who are sitting, and that's just 5 developed countries around the world, which are the major recipients of South African physicians. And the graph on the right, you can see the percentage of South African physicians in total registered in destination countries. And it's changed over time. I mean, there was a peak around 2005 and was coming down in 2017. We know it's going up again significantly now, and I'll say why in just a moment. But even at the lower levels, you're still talking about 2017, 20% of the South African doctor workforce. And we know with nurses and others, it's the same kind of levels. And the graph on the right, you can see that there are factors that do make a difference. Just immediately post the end of apartheid, there was quite a jump, but also quite a return. So many who had been in exile for political reasons returned, but another bunch of people who were worried about what was happening post-apartheid left. Significant issues related to socioeconomic issues in towards 2005. And one thing that made a big difference there was that the UK ended automatic registration for South African doctors, which had been in place, and that led to sort of immediate significant drop. What is interesting is the WHO Global Code of Practice that I mentioned that everyone signed up to had absolutely no effect on immigration of South African doctors, and probably has had little effect on any others. So one of the fascinating things that I found that they showed is the inverse correlation between immigration and GDP in South Africa. So the economic effects are a huge driver of immigration from South Africa. And I mean, that's a big concern. We know it's increasing significantly at the moment. South Africa has been hard hit by COVID and the international economic downturn, etc. And yeah, it is significantly, immigration is significantly increasing again now. So I've adapted, but we came up with 5 propositions in 2002, which are still applicable today, and I'm not going to go through all of them. It's in detail, but obviously developed countries should be training their own, and that's exactly what you are celebrating in the Riverland today, is that local training. There needs to be more of it and more extensive. Then the whole thing of paying compensation, and that's supported by WHO, but it has never happened. I mean, the training costs are huge, and when we lose healthcare professionals, we lose in a huge investment in training and resources as those get lost, and there's no way of getting that back. Linked to that, number 4 is the finding ways to give back or pay forward. And I want to come to an example of that in a moment, but it's important that organizations involved be thinking about how do they compensate for the fact that they've received somebody, and we know that South African health professionals are very well trained. That's why they're sought after around the world, and our training standards are high. Yeah, the disadvantage of having such good training is that we lose more health professionals. We made the point back in 2002 that WONCA, that Paul referred to, and WHO should take a clear stand. And in fact, WONCA did in 2002 develop the Melbourne Manifesto on international recruitment. It took the WHO a bit longer to get there, but they developed the international code. That was a World Health Assembly resolution in 2010. But we know from ongoing monitoring, the last report in 2021, that its impact has not been very good because of countries failing to adhere to it, and that there are all sorts of ways of bypassing it. For example, a country uses a private recruitment agency and they're not covered because they're not a government agency, and they can do what they like essentially, but the government actually then employs the people that are recruited by the private recruitment agency. So one example of giving back, which also goes back quite some time, and this is a collaboration that we developed with the Rural Workforce Agency of Victoria back in the early 2000s, where they had recruited South African doctors, and they actually supported a pediatrician trainer to train trainers in neonatal resuscitation. I mean, there's a long story as to how that came about, which started actually with just a dinner table conversation during the World Rural Health Conference in Melbourne in 2002. And we managed to train trainers in neonatal resuscitation across the whole of South Africa. Jim Thurley was a trainer, was with us for 4 months, and it was an amazing project. The best example is a deliberate play on the fact that the best is the basic emergency skills training. It was rural emergency skills training in Australia, and for copyright reasons, we changed it to best in South Africa. And we did a similar thing, and what is amazing about BEST is that there are still a number of BEST programs, again, it's been renamed since then, that are carrying on in South Africa to train basic emergency skills. But that's example again of an agency that funded work in South Africa to give back and support in South Africa for that recruitment. I'm just going to end off by saying very briefly what we were involved with in the Ukwanda Center for Rural Health that I'm privileged to lead. We have a rural clinical school in Worcester that I showed you earlier when you couldn't see my map. And we are training health professionals across all 5 undergraduate programs that we have in our faculty, medicine, OT, physio, speech, and human nutrition. Nursing has recently been restarted at Stellenbosch undergrad level and will hopefully join us soon. And that's an exciting project and continuing to develop. In the Northern Cape, which is very sparsely populated, it's a bit like the Northern Territory in Australia. We're also developing another site in an exciting initiative. And there we actually learned from our previous development in that we started right from the beginning as a multi-professional program rather than starting with one program and adding others on. Most recently, we've developed a postgraduate diploma in rural medicine to upskill doctors for rural communities, which is getting launched in January. So thank you for the invitation to speak to you, and do come and visit us in South Africa.